You do a very special kind of prescribing using bioidentical hormones, and the world has been used to using and probably abusing the horse-derived hormones, and we know that's one important thing. Then for the male, you have MANopause, the parallel, but spelled with an A instead of an E. Tell us a little bit about what that means and what the way you would evaluate that in men.
Testosterone deficiency, I think, is becoming much more commonly picked up in offices. And again, it's not just about a man's sex life. Testosterone is very important for mental health, for muscle strength, for heart, for cardiovascular purposes, for body composition. And so it used to be thought that, unlike the female who may have a decline in estrogen levels in her late 30s, 40s, or 50s, that we didn't have to worry about this until a man got to be 75 or 80 years of age. That was the thought, but that's clearly not true. And so I'm getting males that are in their 30s coming in to see me with complaints of not feeling well and the constitutional complaints plus libido complaints, and I am finding very low levels that you would have associated with 75-year-old males. We have lots of endocrine disruptors floating around that may be at play, and so these patients require a workup. Sometimes we can identify changeable factors that will lead to an improvement in their testosterone levels. But I think that young males, like in their 20s, probably should have a testosterone level measured as a baseline for future reference. There's a wide range of testosterone. If you look at the typical lab, it's 250 to 1200. And so if it comes in at 300 in the normal range, many physicians will tell patients, well, you're fine. Well, they're not fine. That's especially if they're 35 years old. They should have a level probably 700. And even if a patient has a 500 level, what happens if their normal level was 800 or 900? We don't know where it came from. And there's such variability. I had a 75-year-old man in my office last week who's got the world record for testosterone. His testosterone runs at 1200. And it's unbelievable. He doesn't take it. Every time he goes to a doctor, it comes back from the lab high, like with red flags on it. But he just happens to have high testosterone, and there's nothing wrong with him. There's probably all sorts of males who have normal levels in 800, 900, and when it drops to 400 or 500, they're already starting to feel symptoms. And they're not going to have that picked up unless we know what their baseline is, or they go to physicians who understand that they may have a relatively diminished level. So testosterone replacement is a lot less complicated than the hormonal replacement in women. The one issue that does not seem to be an issue anymore is prostate cancer, in a sense that it was feared that testosterone was a cause of prostate cancer. And I think this has been cleared up. I mean, there's been numerous peer-reviewed journal articles that clearly show that testosterone does not cause prostate cancer. However, if you develop prostate cancer while on testosterone, you have to stop. At least that's what the current standard treatment is, because it may promote further growth. And when you give testosterone, you must monitor by examination and by PSA test whether there's any rise, because if that patient had an occult or a hidden or small and apparent prostate cancer, it could start to grow. But I think the men have been cleared more of the safety issue, and now it's just a question of interpreting their lab results to see whether they need replacement or not.